Thanks, Adi.
Okay. Can you see my slide?
Yeah.
All right. Good afternoon, everyone. My name is Hade Kola Jeremiah, and I'm one of the senior clinical fellows in stroke in Royal Preston Hospital. This afternoon, I'll be discussing CT perfusion in extended thrombolysis window. This is a tool that we use quite often. And for all of us who I believe are involved in stroke care, we need to be able to identify, interpret it a bit, not like a radiologist, but at least to be able to make informed decisions based on the CT perfusion finding. And I will discuss with the aim of hoping that we'll understand that why we do CT perfusion and also how do we apply it to our day-to-day practice and what are the limitations of these two. Because when we know the limitations, then we can find a way around it and also know when to take the results with, let's say, a pinch of salt. So CT perfusion is a dynamic scan that we do, is contrast study, which we can use to differentiate area of damage that are salvageable. That is, those are the area we call penumbra. Those are the areas that they've not yet died, but if the ischemia persists, they are likely to die. While the core is, we describe it as the dead brain tissue, and they are damaged, so we can't reverse the damage. So when we see stroke patients, the aim of our acute reperfusion therapy, either thrombolysis or thrombectomy, is aimed at salvaging the penumbra. And we see patients a lot that come into the hospital with stroke that we are not able to tell when exactly did the stroke happened. Maybe the patient is aphasic, they are not able to tell us this is where it happened, or maybe it's a wake-up stroke, which is a significant amount. About 20 to 30% of ischemic stroke are wake-up stroke. We don't know the time of onset. How are we able to decide what the perfusion therapy is available to treat such patients? That is what CT perfusion can help us to do, because it's not just about the structural damage that we can see on CT scan, that's the non-contrast CT, but also the hemodynamic changes that has led to it. The CT scan won't be able to tell us this is the core, this is the penumbra. But with CT perfusion, we're able to judge accurately or to a good extent that this is the core, this is the penumbra, and we can then save the penumbra. Now, when we see patients with stroke coming, we all know that the damage tend to progress with time. However, some do progress faster than others. And on this image, we can see on the right, on the left MCA part of the CT here, this is a non-contrast CT. On the first one, at 0 hour, we can see that, early ischemic damage, we can see the penumbra, which is the green coded part of it. However, as time goes on, the penumbra tends to reduce in size, and the core, which is the purple part of it, is getting larger. However, when we look at this scan here and the first one, now within 6 hours, this patient has progressed rapidly. However, someone at 24 hours has not progressed rapidly. What are the changes? What are the hemodynamic factors that has led to this? So CT perfusion is able to tell us to some extent, this patient is likely to progress, this patient is not likely to progress, this is the state of the core, this is the state of the penumbra. CT head cannot tell us that. CT angio is a reasonable tool as well. It's not able to tell us that this is the penumbra or the ischemic core. So why do we use CT perfusion? MRI is best to identify ischemic stroke. However, it's not readily available. and CT perfusion is readily available, is something that can be done quickly. And with that, we can get to know what the core is, what the penumbra is, and then take a decision. And there is an algorithm, which is the artificial intelligence, which is able to read and give us the data, the volume of the core, and also the penumbra, which is which TMAS is measuring. I will define the term quickly. But before I define the term, I just want to go over the criteria for extended thrombolysis window. Most patients come in within this window because 4.5 hours. Most patients do miss that 4.5 hours. And with this extended thrombolysis window, up to 9 hours from when they were last seen well, or wake up stroke, as the case may be, they could have thrombolysis. However, to be able to do that, we need to understand the functional changes that is happening in the brain, and that is what CT perfusion tells us. If we're using CT perfusion for a stroke of unknown onset time, we need to identify first when was the patient last seen well, and then determine the midpoint of sleep. And from that midpoint of sleep, we're able to calculate 9 hours from that time. We'll do some examples and we'll apply this. And to decide if the patient has could have thrombolysis or not, they will need to fulfill some criteria based on the CT perfusion, which will involve the mismatch ratio greater than 1.2 and the volume of the mismatch greater than 10, and the ischemic core, which is the area of the infarct itself, less than 70 mil. If it's a known onset time, however, patient is coming outside of the 4.5 hours, they could be eligible for thrombolysis up to 9 hours. So same criteria applies as well. And this is how the CT perfusion looks like. For different model of it, the image might appear a bit different in your center. However, the key things that we measure is the cerebral blood flow, which is the amount of blood flowing per unit time in 100 grams of brain tissue, and is a marker of core infarct. The infarct that is already there is a marker, cerebral blood flow is a marker of the core infarct, while Tmax is the marker of the penumbra, which appears as the green part of this scan. And for us to be able to make a decision, we need to consider both, as in this case, the cerebral blood volume at 30% threshold, which is what is used, is 49 mil in this patient, which means it's less than 70 mil, and Tmax, which is the green part here, is 112 mil. And when we subtract both, it will give us the mismatch, which is 63 mil. And mismatch ratio is 2.3. That is, when we divide this 112 by 49, it will give us 2.3. So this is what the AI will calculate, and based on our assessment of the patient, we can then decide, looking at this criteria, looking at this CT perfusion reading, it is suitable to thrombolyze the patient. Now, when we look at CT perfusion, we're looking at the cerebral blood flow, the cerebral blood volume, and also the MTT, mean transit time, and the Tmax. And the cerebral blood volume is the amount of blood flowing through 1 gram of the brain tissue when it's compared to the other hemisphere that is not affected by the stroke. So this tends to measure how much of collateral is supplied to that part of the brain that is damaged. And it can give us an idea of how these patients are likely to progress, because if they've got good collaterals, that means they wouldn't progress faster as someone who has got no collateral to that part of the brain. The mean transit time is another value that we measure, which measures the time taken from the time the contrast is given into the artery and to the vein across the capillary bed. And this is a predictor of ischemic core when it is compared to the cerebral blood volume, which is the time taken for the brain for the blood to be delivered relative to the normal hemisphere. Yeah, this is Tmax, which is the time from the start we inject the dye to the maximal intensity of the contrast. So how is it done? Often what they do in radiology, the radiographers, they put in a dye, and the dye goes through the vein, and then to the arteries of the brain, and then it goes to the vein through the capillaries, and then it's washed out. So the process of it going through the brain, a dynamic image is being taken by the scanner, and with that they're able to calculate all the indices we are looking at. With this index, we could also calculate the hypoperfusion index, which is the degree of the perfusion to that part of the brain, and is a measure of poor collateral flow if it is greater than 0.34. So this image is just showing us another patient with who has had a scan, and they've got a core. This is the CBF, which measures the core. I'm using the pointer now. This is the core, 49 mil, and this area of the green part is the penumbra, which we are aiming to save. So when we have this done and we want to interpret, we need to ensure that some things are in place, like assess the quality control of the scan that has been done, because if the scan is done wrongly, the interpretation is likely to be wrong. So there is a graph which I will show now. So for every patient that has had a CT perfusion, this graph will always be there. And this graph is important because on this graph, we can see we've got the scan time. It is meant to be done within 60 seconds. The whole of the contrast injection and the washout through the vein is meant to be done within 60 seconds. And then on this side, we've got the change in the attenuation as the dye goes through the different parts of the brain. The green portion here is the average of the bolus of the contrast flowing steadily, while the AIF is the arterial input flow, and this is the venous part. Now, when we look at it, this three graph must always start from 0 for the scan to be accurately interpreted. It must start from 0, and the arterial phase peak first. The arterial phase will always peak first before the venous phase. If the venous phase is peaking first before the arterial phase, that likely means the interpretation will be wrong, and we can't use that to take a decision for thrombolysis. So first we have the arterial phase, which is this curve in red. It goes nice and smoothly like a Gaussian curve, then followed by the venous outflow function, which also peaks after the arterial phase. So we need to ensure that this curve is normal before we go ahead to interpret CT perfusion. So when we interpret CT perfusion, we need to ensure that this graph, we take a look at it before we interpret. There could be reasons where you will have spikes. When we have spikes instead of a peak, that's likely to be due to motion artifacts. That is, the patient is moving his or her head during the period of the scan, and that means we can't interpret it correctly. So how do we apply this to our patients? For thrombolysis, it's based on EXTEND trial, which was done in 2013, and this trial considered patients for thrombolysis up to 9 hours after the onset of the stroke or midpoint if the stroke is of unknown onset, and they were treated with alteplase, and they had good functional outcome. That's when they used the MRS compared to those who weren't treated. The risk of symptomatic ICH is 6%. However, the overall benefit of thrombolysis outweighs this risk. Also for thrombectomy, we use it as well using diffuse trial and Dawn trial. Yeah, I think for the other application of this CT perfusion, we can use CT perfusion also in areas of stroke mimics, especially patients with seizures. They could either have hypoperfusion or hyperperfusion, depending on the phase of the seizure, like if they were in their ictal phase or post-ictal, depending, and it's often on both sides of the hemisphere, unlike if it were to be due to stroke. And there are ongoing research about further application of CT perfusion. Now, one will want to wonder if we can do a lot with CT perfusion, why not go ahead to do CT perfusion instead of doing a CT brain first, non-contrast CT head first? Now, the relevance of that is that CT perfusion, as good as it is, it has some limitations. One of the limitations is that we won't be able to see some subcortical stroke or lacuna infarct, and it's also prone to artifacts from the process of doing the scan itself. So going forward, we'll look at about 3 cases of patients who had CT perfusion. The first one is a 49-year-old female, last seen well at about 12 a.m. and she woke up the next day with dense right-sided weakness, and NIHS was 20. She arrived ED 2 hours later, and prior to this, she had MRS of 1. Now, if we were to use the 4.5 hours coding window, this patient wouldn't be for thrombolysis. However, she was last seen well at 12 a.m. and she was found 7 hours later. If we were to calculate the midpoint, it will be at about 3 a.m. 3:45 a.m. in the morning. So with that, we had 9 hours, and that will mean that this patient will be within the thrombolysis window because she's arriving 2 hours later from this. So she still has about 2 or 3 hours more within the extended thrombolysis window. So looking at the CT head, we can see an hyperdense vessel sign in the left MCA, which suggests to us that yes, this patient is having a large vessel occlusion. And the aspect was about 8. And on the CT angio, she had a left M1 occlusion here. Then to take the decision for thrombolysis, she had a CT perfusion. So before we interpret the CT perfusion, we have to look at the curve first. And on this graph, we can see that, yes, the 3 curves are starting from 0, and the arterial phase is peaking first before the venous phase, which means that, yes, we can reliably interpret this CT perfusion. Now, the AI has calculated the CT, it has calculated for us the cerebral blood flow. Less than 30% is about 31 mil here. That's the core. And then the Tmax, which is a marker of the penumbra, is about 128 mil. When we calculate the mismatch volume, which will be the difference between both, is 97 mil, and the mismatch ratio is 4.2, and CBF is less than 70 here, which is good. And then the ratio is 4.2, greater than 1.2, and the mismatch is greater than 10 mil. So this patient meets the criteria for thrombolysis, and she was thrombolyzed. Now, this is important. Before she was thrombolyzed before she went for thrombectomy. Now, for patients that are presenting to hospital where they will have to refer to a thrombectomy center, This is important because they could have this reperfusion therapy, thrombolysis, before they come down for the thrombectomy, which would improve the outcome. So to approach patient practically, this is what we need to do. First, establish the midpoint. If it's a wake-up stroke, establish the midpoint. And when we've established the midpoint, add 9 hours. Are they within, then the time they presented, is it within that 9 hours? If it's within that 9 hours, then with disabling stroke symptoms, they need to have CT head, CTA, and CT perfusion. And with that, they can be thrombolized if no any other clinical contraindication. All right, so we've got a second case here, which is a 62-year-old female. She came in, she was brought by ambulance after the husband found her at about 8 a.m., less responsive and not moving her right side. She was aphasic and NIHS was 24, which is a quite, this is a severe disabling stroke. She went to bed at about 9 p.m. Now, she had a CT head, which is showing that she has an early ischemic change on the left MCA. Now, she's 12.5 hours from the last time she was, she's got a left MCA, early ischemic change, aspect is 5, and 12.5 hours from the onset. So this lady wouldn't be for thrombolysis because she's out of the thrombolysis window. And she had a CT perfusion, CTA, which shows that she's got a left M1 occlusion, which we can see here. This left M2 occlusion. And then she had the CT perfusion. So she's not progressing as fast as one would expect for someone who was lasting well 12 hours before the onset. So looking at this, the core infarct is 36 mil, which is less than 70, and the Tmax is 72 mil, and the mismatch is 2.0. So this is an ideal candidate for thrombectomy if she's out of the window. I've got another case here of a patient who was found outside the pub at about 7 p.m. and patient was not oriented, he wasn't speaking too well, and he was presumed to be drunk, and they felt, yeah, this is likely more of alcohol-related alcohol intoxication. However, the following morning, he was found to have left hemiparesis. This is about 13 hours from the onset, and NIHS was 27. So looking at the CT head, it's got early ischemic changes on the right MCA territory, and aspect is low, 3. So patient had a CTA, which shows a large vessel occlusion causing the symptom, and then had CT perfusion. So if it were to be based on the 4 hours onset, 4 hours from onset time, this patient wouldn't be eligible for any reperfusion therapy. However, this patient had a thrombectomy because of the favorable CT perfusion profile. Looking at the CBF, which is a marker of the core infarct, it is 40 mil, which is less than 70 as per the guideline, and this is the salvageable area, 134 mil, which is a large chunk of brain to be saved, and mismatch ratio of 3.4, and the patient had thrombectomy and improved. So when we are looking at CT perfusion, what are the pitfalls we need to be aware of? If the patient is moving their head quite often, it could lead to multiple spikes on the curve. And also the way the scan is done, our radiographers need to be good with it. If they are not good with it, it's likely that they will be giving us a false result. And one of the ways you could see it, a false result or a pointer to it on the scan, the volume of the T mass will always will come as infinite, which means that this scan cannot be interpreted. So when that happens, we need to have a look at the graph to see if it was done properly. The limitations to this use of this scan could also be related to the interpretation. CT perfusion can underestimate the core or overestimate the core. It can overestimate the core when it is done too early, and it could also overestimate the penumbra. So we shouldn't interpret the CT perfusion alone. It needs to be interpreted in the context of the CT head, the CTP, the CTA, and the CT perfusion. So we need to consider both scans, consider both 3 scans together. Now, this is more like an algorithm to keep at the back of our mind when we've got patients with disabling stroke symptoms and we are not able to establish the onset time, or patients are presenting outside of the 4.5 hours, we need to consider first, what's the NIHS, what's the MRX. If NIHS is more than 4 or is disabling stroke, that means they could be for thrombolysis, and we'll calculate 9 hours from the midpoint or 9 hours from when they are last known to be well. If they are within the window, they will need to have a non-contrast CT and then CT perfusion. CTA can be done, especially if we are suspecting a large vessel occlusion or if patient has a fluctuating neurology. And then once the CT perfusion is done with the CT head, we have to review the whole images. Then looking at thrombolysis decision, we check the CT head, no bleed. CTP, first check the curve. If quality check is fine, then go ahead to check the mismatch ratio. If it's more than 2, mismatch volume more than 10 mil, or core infarct less than 70, then the patient should be eligible for thrombolysis. If the criteria are not met, this patient will not be eligible for thrombolysis. Now, when we look at this criteria, we take them together. It shouldn't be just 1 or 2. They must meet these 3 criteria. If the patient does not meet these 3 criteria, the risk of bleeding is higher, and there is no research, there is no randomized control trial to back that up. So the only evidence we have is for the patient to meet these 3 criteria based on the CT perfusion. Then the patient could be eligible for thrombolysis or thrombectomy, as the case may be. So in summary, with CT perfusion, we are able to have an understanding of the hemodynamic process that is driving the process of the stroke evolution. And it's a useful tool that can help us identify patients who will benefit from reperfusion therapy outside of the 4.5 hours. And we need to consider the history and the finding on the CT head, not just the CT perfusion. It must be used in adjunct with other neuroimaging. And then with the automated software finding, we can look at the infarct size, mismatch ratio, and take an informed decision either for thrombolysis or not. So yeah, that is all. And yeah, I'm open to any question. And this is just if you could give a feedback. Yeah. So any question?
I think Kim's got a hand up.
All right.
Of course I have. You couldn't get away without me asking a question, could you? So hi, I'm Kim. I'm one of the stroke nurse consultants at Furnace General. And obviously, thank you for doing that talk. It was very straightforward for us to get our head around because we don't have it yet. We're in the process of getting our CT scanner up and running, and obviously now this is part of our little training session. So thank you.
You're
So
welcome.
just want to be able to ask, obviously the cases you've presented are quite clear cut and it fits the 3 criteria. Just because obviously you guys have got more experience, is it generally as clear cut as that, or is it a little bit of, is it not as straightforward sometimes? Come on, hit me with the truth.
Yeah, Kim, you're right. At times it's not straightforward. Like, you could have a patient who would meet one of the criteria or two, but for thrombolysis decision, it needs to involve both 3 criteria. They need to be met before a patient will be eligible for thrombolysis. And if the 3 criteria are not there, then we need to then have a look at the scan itself. Was the procedure done rightly? If it was done rightly, then that means it's either we are looking at a subcortical stroke or we are looking at a stroke mimic. And in that case, we might, there's no evidence to back up thrombolysis for that patient, especially when they are outside of the golden 4.5 hours.
Okay, thank you. Can I
You're
ask one
welcome.
more question as well?
Yeah.
So, and I've heard as well that sometimes CT perfusion scans can sort of sometimes show like nothing, but obviously then you've got a patient in front of you with symptoms, and obviously then in the normal world, ignorance is bliss, and you would treat that patient as a stroke and but
Yeah.
obviously then that would throw a little bit of a curveball. How do you normally manage that in real life?
Yeah, so what we do often is that in such instances, if there is any evidence of large vessel occlusion, then we go for thrombectomy. But often it's less likely there will be a large vessel occlusion, and the finding on the CTP will be normal. We only see that case in sense of you've got a subcortical stroke or a lacunar stroke that is small to be picked up on CT perfusion. So in such instance, we don't thrombolyze. We go ahead to do MRI brain, which can be done. At times, it's not done within 24 hours, but the patient wouldn't be for thrombolysis. But for thrombolysis decision to be made, those 3 criteria are important.
Thank you.
You're welcome.
I just wanted to ask Addy as well, for extended thrombolysis, is there a certain, so like for thrombectomy, they have to have a certain MRS and NIHSS.
Yeah.
Is there a certain criteria, or is it clinical judgment?
Yeah. Excellent question. Yeah, for thrombolysis decision, we don't use the MRS. However, if we look at the quality of life of the patient that is bedbound, and thrombolysing them will make any much change to their quality of life. But if they've got some sort of independence and maybe they can use that hand to eat, then you might want to consider them for thrombolysis, despite the fact that the MRS is greater than 3. So more of, is it a disabling symptom, and how will it impact the patient's day-to-day functional activity? If it's going to make much impact on the patient outcome, then I think it's reasonable to give that patient a benefit of thrombolysis.
Thanks, Addy.
Yeah.
Okay. Any more questions?
No, that was really well explained. Thanks, Addy.
You're welcome, Penny.
Thank you. Thanks very much.
Thank you so
Addy.
much.
Thank
All
you.
right.
Thank
Thank
you.
you.
Thank
you.
you.
Thank you.
Thank you.